Good afternoon. Welcome back to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, chair of the department. Here are the ground rules. I think you probably all know them by now. Put your Zoom window in full screen mode. If you have questions, type them in the Q&A box. We'll try to get to some of them. And we will post this tonight on YouTube. We're closing in on 2 million views in this series. Well, whether you date the start of when you started to realize how serious COVID was going to be by the lockdowns in San Francisco and in California, or by WHO declaring a pandemic, which occurred on this day in 2020, or by the first grand rounds in this series, which was on March 19th, or something else, it's fair to say it has been a year, any way you cut it, since COVID really consumed our personal and professional lives. Somehow that year seems like both the blink of an eye and a lifetime. While the impact has been profound and tragic in many ways, we have some things to be grateful for, including the performance of San Francisco. We still have fewer than 500 deaths in the city, obviously all of them tragic, but a far lower death toll than any major city in the United States. And I've calculated that if the country had San Francisco's per capita death rate, about 350,000 people would be alive. The response here at UCSF has also been really extraordinary and to me, quite inspiring. So I thought it'd be useful a year into this to take stock of where we are a year later. And while I could have chosen any number of thoughtful colleagues to help us out, I've chosen 3 of the folks that I've relied on the most personally to be educated about various perspectives of the pandemic. And we'll spend the hour just chatting about where we've come from, where we are today, and where we think we'll be in the future. I can introduce them briefly because if you've been following this series, you know them all well by now. The first is Kirsten Bibbins-Domingo, who is chair of our Department of Epidemiology and Biostatistics and vice dean for population health and health equity in the UCSF School of Medicine. Kirsten also co-founded the UCSF Center for Vulnerable Populations and chaired the U.S. Preventative Services Task Force from 2014 to 2017. She has been a local and national and international leader on particularly on issues around health equity and diverse populations. So Kirsten, thank you for joining us. Next is my colleague, Peter Chinhong. Peter's professor of medicine based in the Infectious Disease Division at UCSF Health. He's also associate dean for our regional campuses and directs the immunocompromised host infectious disease program at UCSF. And Peter has been a go-to person, both for us locally and in the media for many aspects of COVID, but I'd say particularly some of the more clinical aspects of the pandemic. And last but not least is George Rutherford, who's professor in the Department of Epidemiology and Biostatistics. He serves as our medical director of prevention and the public health group. George focuses on epidemiology and prevention of infectious diseases. And he, of course, has been become legendary for his pandemic updates. And he just chronicled them the other day, and he says he's done about 200 of those over the course of the past year. So, George, we are all grateful to you for keeping us up to date on what's going on. So let's go ahead and get started. And I'll throw one out for all of you first. Tell us about your first inkling that this was going to be a very big deal. How did that dawn on you and when? So why don't we start with Kirsten?
Thanks, Bob. Yeah, so I think like many, we watched the reports from the news. Early on, we saw things that were happening maybe in New York, maybe the chatter amongst us as a academic health center about what we should do to prepare for clearly what others were worried about. I think for me personally, it was shifting from me complaining and worrying in front of my family and who were like, what are you talking about? Till the day I came home and they said, the NBA has canceled a game. Rudy Gobert has COVID. And all of a sudden for them, it was the reality. And I think that is when the things that I had been saying were more than, oh, mom is just the doctor who's always worried about everything, to something really different has happened. And so I think that was the defining moment in my household and one that I remember. And yeah, the rest is history.
Yeah, the rest is. Peter, how about you?
I also remember that NBA cancellation really vividly as well. And it, for me, reminded me of when Magic Johnson had HIV. And I think it really sunk into all our consciousness that COVID wasn't just something far away in a far off land. It was actually here. I think another, Tom Hanks and his wife getting it in Australia was another thing. And then metaphorically, just seeing that cruise ship, the Grand Princess in our bay and passing it on the Bay Bridge really sunk home that literally it was on our shores.
Mm-hmm. Yeah. How about you, George?
Well, I follow this stuff pretty closely. I was worried.
Yeah, I would hope you'd be at least a few days before me. So
I was worried the first week of January when the first sequence came out, and you could tell that it was a beta coronavirus. Something we've had two major worldwide pandemics of beta coronaviruses in the last 20 years, between SARS and the Middle East respiratory syndrome. And I thought, ruh-roh, in the immortal words of Astro.
Yeah. Well, let me ask you about that though, because yes, you follow this carefully, but for those of us that don't, there have been these scares over the last 20 years, 5 or 6 of them probably. And most of them, if my reaction as a relative layperson in this was, oh my God, it's going to be 1918 again, in most cases, or I guess in all cases, that was not true. So was there a clue to you in January that this was going to be the big one?
Well, that it wasn't predominantly nosocomial. I mean, that's what limits that's what limited SARS and MERS, was that they were predominantly nosocomially transmitted, which turns out because they have tropism for the lower respiratory tract as opposed to the upper respiratory tract, and that's the difference. And yeah, when you started to look at, by late January and the first articles were coming out of Wuhan, you could tell that this was really community transmission, and it didn't have those giant amplification events like having all the senior medical students examining a SARS patient in the ICU in Hong Kong, as a sort of one of those big things that got 100 cases going. So I was, I had a feeling this was going to go seriously south on us fairly early on.
And when I'm spacing on when we learned about asymptomatic transmission, but it seemed like that was sort of another ramp up in the level of concern and how big it was going to be. Do you remember when that was? And did that change your thinking about it, or were you already there?
I think we really learned about it around January 10th, and that really, and you have to be reading the ProMed websites to get this stuff. It's not like out in a journal or anything. Yeah. But it really flipped me to say that this is going to actually be, really big, and on the order of possibly on the order of a major flu. Influenza A shift. Mm-hmm.
And Kirsten, one of the things that's been most remarkable about the year has been the sort of the Venn diagram of health equity and disparities and COVID. I'm guessing that as soon as you saw COVID emerge, you knew that was going to play out at some level. But then we had the layering on top of it of Black Lives Matters and George Floyd and Breonna Taylor. So tell us about your evolution from hearing about the pandemic, taking it seriously because obviously of the NBA and your family finally believing you. Your sort of understanding and sort of prediction, I assume, that there's going to be equity issues and diversity and disparities that arise. And then the sort of political context. How did all that play out?
Yeah, it's really, really interesting. I remember early on in the pandemic, the question is, well, what are you going to do in this crisis? And for me, I'm an epidemiologist, but not an infectious disease epidemiologist. I am a physician, and I said, okay. And there was a lot going on at UCSF, and I'm also a department chair. So I said, this is one where I'm going to focus on taking care of patients, backing up other people who are going to be deployed in other places. And that's what's going to happen. And it was pretty clear at the general where I see patients that all the patients we were seeing with COVID were Latino patients. And that even as we were in lockdown in San Francisco, even as our cases came down, we were still seeing a lot of Latino patients, and all of the patients in the hospital were Latino. And I think for us, that started to make clear that this was going to be something everyone was going to worry about, everyone's life was going to be affected, but that really the impact was going to be felt disproportionately in some communities more than others. And I think when you look at some of the early responses in the community work from Diane Havlier and Karina Marquez and others, it was really motivated by seeing what we were seeing at the general and saying, well, we have to do more because these communities are going to be more affected. You mentioned about asymptomatic spread. I still remember Diane's study with Karina and with Gabe Chamey really was done at the end of April, and that's where we started to really learn the burden of asymptomatic PCR positive cases. At least in San Francisco. And San Francisco, in response to that study, changed its testing criteria from just testing asymptomatic to trying to test more people. So I think both the response of those of us who take care of patients in these communities to then saying, well, we need to know more, and that driving how we understood the response in San Francisco is really an important story. As me, for somebody who's not an infectious disease epidemiologist, but thinks about health equity, it was pretty clear in reading that, everyone who studies pandemic knows that this is what's going to happen. Poor people, poor communities, communities that lack resources defined in a variety of different ways, oftentimes bear the brunt of a pandemic. And that all of our strategies to mitigate spread, to protect individuals, oftentimes are those same strategies that are more challenging in some communities and lead to these great inequities. So we realize that, but then the national conversation and context that really was about our reckoning with racial injustice, catalyzed by the most recent killing in George Floyd, but really sparking this national conversation, which many think became the focal point nationally because we were all at home, like watching these images at the same time on the screen, not because there was something extraordinary, unusual. This was the latest in the series, but I think it's that national conversation happening about racial injustice. At the same time, we were seeing these really stark national numbers and disparities in who was dying of COVID-19 that came together in a way that in some ways one could say came together coincidentally. In some ways one could say they came together because we were all focused at the same time, the entire country, on the same set of things.
Interesting. And either George or Peter, any comments on that and the issue of disparities and how it played out for you?
Yeah, so one comment I wanted to add as a parallel comment to disparities is something that took me in a blindsided way, which was the whole hate and violence against Asian Americans. I think that was really unexpected. I think early on the WHO anticipated this by changing the name from Wuhan virus. We were calling it Wuhan virus for the longest while to COVID. But yet our political leaders still used, Kung flu and Chinese virus, and that spewed so much hate and violence. And, I myself saw this elderly Asian gentleman almost run down in the middle of the road with somebody yelling out China virus at him. And now to this day, it's still persisting in the Bay Area. And I think that was really shocking to me. And I think, was one of the reasons why I think I started to speak up and rally, help join a bunch of faculty to go on media, particularly Asian media, to educate the community. So I think that, they were expected things like Kirsten was saying, but they were unexpected ways in which the virus and the fear of the virus played out in society.
Yeah, George, I've been thinking a lot about HIV lately and sort of the lessons from the 80s. And we worked a little bit together then, and you were doing this work back then. What do you see as the parallels and the differences? As Kirsten was talking about, sort of, we knew it was going to hit a population. HIV very quickly was hitting very discrete populations and populations that were also massively discriminated against. It colored the political response in a big way. How did you, as you thought back about the 80s and now, how did you see parallels and differences?
Well, there are a lot of parallels, and some things are different. Admittedly, in 1984, 85, we were still, floundering around about, really ratcheting down once and for all modes of transmission of HIV, and there was still stuff about schools and casual transmission and all these sort of buzz terms for fomite transmission or whatever. And I think we finally put that behind us by about 85, and we're really concentrating, well, almost all behind us by 85. And we're really concentrating on sexual transmission, which, you know, it's a little bit easier. It makes it somewhat simpler in that there you don't have as many contacts as you do if you go on to Muni and breathe.
Mm-hmm.
So it's, you know, it's a little bit more circumscribed, but on the other hand, there are a lot of parallels, and you know, the whole sort of unknown quality to it, and people being resistant about advice, and national level politicians flubbing it, and you know, and I guess the one real difference here is that CDC failed to ride to the rescue. And I think that was really very disappointing for many of us who've spent our entire careers heavily intertwined with CDC. Here's an agency who's won.
The CDC didn't this time, but did in the 80s.
Yeah, they put together the National Kaposi Sarcoma Case Control Study. They really nailed it down as hard as they could. They didn't have the virology capacity. That was really at NCI and other places. But CDC is an agency that was put together in the 1940s specifically for this purpose, and they, you know, and here's the big one, and they flubbed it.
Yeah.
So I mean, that was really disappointing, I thought.
Yeah, I mean, some big differences that struck me. You know, one is it became fairly clear early that it was not, there was not a huge risk to the general population and through casual contact, but then the risk was to groups that were, you know, highly stigmatized. And the political response was colored by that in the 80s. You know, Reagan never mentioned the word AIDS in a speech until 6 or 7 years into it. Here, the reason for the political dysfunction was somewhat different. So let's pivot to the political issue for a second, and we'll get to some of the clinical issues. But when did you have a sense that the politics was going to be so divisive that masks would become a sign of what team you're on? Peter, how did that evolve for you?
It evolved as a gradual awakening. I think the first clue was that the CDC wasn't front and center as being, you know, I remember the first COVID patient I saw, and usually back in the day, meaning like more, you know, a few years ago or whatever your interval is, you know, there'd be updates all the time, and you know, they're not only updates about prevention, but there are updates about therapeutics. And I remember sitting, you know, we had Jen Babick, Brian, and all those folks were giving us education, and we were sharing it amongst each other on the web, on Twitter, because nobody was telling us what to do. And, you know, we came up with our own first guidelines from Jen Babick's, sort of like looking at the Chinese data in the New England Journal. And, you know, it took off like wildfire all over the country. It was translated into like 9 different languages and scripts. And when we did our first how to get remdesivir, like thousands of people wanted it from pharmacists. And that really speaks to that influence of politics on the CDC. And so I guess my first awakening was that we were trying to do this on our own. And where was the people telling us what to do? And I can just like click on the website, and it wasn't there. So, and then that evolved over the year. And then there were the crazy moments when I felt more incensed, like, you know, the mask, of course, but then the hydroxychloroquine issue, then the, you know, don't test contacts of positive patients. They were all, and then the way remdesivir was distributed, there was so many cases. Then when President Trump got sick and all of his riding in the SUV, I mean, there were so many times that we had to sort of step up and sort of like come back to science.
Yeah. Well, it's actually interesting. Just to pick on Peter's point for a second, I hadn't really thought about that. You know, your ID group, and really across all 3 of our main sites, came together spectacularly well and became this extraordinary trusted source of information. And until you just said that, I hadn't realized that you were filling an information vacuum, that maybe, you know, in a different world, all of that would have been coming at us every week from the CDC, and that's where you would have clicked to get it, and you recognize that it wasn't happening. So you felt that. That's great. Kirsten, I'm sorry, go ahead.
No, I love hearing Peter recount sort of that whole chronology, and I think the politicization was, we think of it obviously because the failures and the way in which the politicization played out on the national stage really colored everything about this. But I think it's really interesting for our state in particular to think also the ways in which it played out locally. And for me, the first one was, I was not doing interviews like George and Peter, who were always in the media answering questions, but some reporter did get a hold of me at some point and asked me to comment on masks and the literature on masks. And I said something like, it's a good idea to wear masks during the pandemic, and the literature supported that. And I got a whole bunch of emails the next day, really, just vile, repulsive emails from people saying, how could I have possibly said that? And a few weeks later, that was when the public health officer in Orange County resigned because people were petitioning on her front doorstep because she had issued a masking order. And it was pretty clear that there are many local public health officials who really bore the brunt of like being the messenger of just common sense, evidence-based public health practice, and who were resigning because they were really in the crosshairs during this entire time. And when me, as a little academic saying masks are important, is going to get personal emails back from people, you realize that you're in a much different environment than any of us were used to.
George, how did the politics play out for you?
Very, very similarly. I mean, I as someone who was working for the city health department here in the mid 1980s, I was very impressed with how the city handled this. I was in a meeting with Grant Colfax and other people day one, right? And before any of the lockdowns, before anything. Remember, the city declared a state of emergency in February, even before the first case was diagnosed. And we had extremely cogent discussions about what are we going to do about Laguna Honda? Yeah, number one action item. And then moving down through everything else about what could you really do as a county health department. And I think they had everything very much in front of them and were really on top of it. And as you said, there have been unfortunately 400 and I can't remember the exact number, Bob. I'm sorry, 420 deaths.
Yeah, that's right.
And in 1918, when San Francisco had a population of 350,000, there were 3,000 deaths, right? And we're talking about the same mitigation measures.
Yeah.
Right? So big difference. So when people say to me, how could you have, what do you think, how could you have done this? I say, well, what's your vital status? Are you alive or dead? Right? You're alive. Oh, I guess it worked then. Huh? I mean, it's real simple. We've had, thousands and thousands fewer deaths here. And in California, I calculated the other day, they had 4,500 fewer deaths in Texas and 2,700 fewer deaths or something like that than Florida. Mm-hmm. And so people can point to this stuff all they want, but they're alive and pointing, not dead and pointing.
Yeah. Just one last question on that, and then sort of pivot to a few other things. But when I point out how well San Francisco has done, inevitably you say, well, that's not fair, younger, weather, tech, populate, everybody's at home at Zoom, on Zoom, blah, 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 not the political response, not the health department, not UCSF, not people paying attention to the public health measure. What's your response to that when you hear that?
The cumulative incidence in the Mission is half of what it is in East Los Angeles. Okay. So if you want to really look at real comparators, we're doing much better than real comparators.
Yeah. Yeah.
I think like everything in the pandemic, it's all multifactorial, and we are fortunate in San Francisco that most of these threads worked in the way that they needed to. Most of these sectors did the things that they were going to. We still have the big disparities, but we have also tried to work both, individually and individual efforts in the communities, but also together with departments of public health. And I think it is all those that have come together in exactly the right way in San Francisco. It is no one entity deserves the credit, I think, but a lot of things did come together in the right
And I
way.
think the Bay Area is very aligned politically, and because the pandemic was so politically galvanized in terms of protection, that when you look at Southern California, which is there's so much heterogeneity, we almost like San Francisco had these henchmen of counties surrounding us, where everyone was aligned and sort of listened to what London Breed and Grant and all these folks did or said we should do, whereas there was very, very mixed response in Southern California.
Yeah. And the lockdown, if you remember that the lockdown order came on March 16th, and there was a reason for that, right? It was the day before St. Patrick's Day. Los Angeles, the Southern California didn't happen until Friday, and it didn't really even happen until the following Monday. Nobody paid any attention to it for 3 days. So, and that 1 week difference was huge. And that basically meant Los Angeles had many more seats to deal with, many more chains of transmission to deal with, and I'm Southern California in general. And they've never recovered from it. That's what the difference a week makes.
So maybe one last question about a year ago, and then we're going to pivot to today. What did you think? I don't think I asked you this, George, back then, but I remember having a grand rounds, maybe I did, where I asked Joel and maybe Diane and Annie about sort of what's going to get us out of this mess and when. And I think the most common answer was therapeutics, and it was by next summer. I don't remember, maybe I'll go back and look at the tapes, whether anybody said vaccines and they will be approvable by November. I don't think anybody said that. So Peter, what did you think when this sort of really washed ashore and you were trying to figure out what the end game is going to look like? What did you think it was going to be?
I thought it was therapeutics too. I thought it was a Tamiflu for COVID, and we just dispense it to everyone in the outpatient setting, and we would clamp down outbreaks in nursing homes using a pill.
Yeah. Let me clarify, because we do have a lot of lay watchers here. Tamiflu does not work for COVID, right? We're just to be clear, right?
Yeah. So the analogy of Tamiflu to influenza.
Right, something like Tamiflu for COVID. And you thought that was going to be available. When did you think that was going to happen?
I thought, well, at that point, we were sort of like still in the realm of teaching an old drug, new tricks. Mm-hmm. So I thought with, the efforts of UCSF amongst other institutions and sort of like doing this big bioscan of available compounds, that somebody in that matrix would discover the magic pill, the magic bullet, so to speak. And, we'd all be saved. But of course, that never panned out. And, we have to do rational drug design.
Yeah. George, what did you think was going to happen? If you say I predicted that Pfizer would produce 95% efficacy results on November 8th, I am going to go back and look at the tape. And so go ahead, tell us what you thought.
I hope I said vaccine. It's not, I'm not going to step on Peter's toes about therapeutics, but that's what got us out of Ebola. I mean that was my sort of that and Zika were my most recent experiences dealing with stuff, and these the adenovirus vectored vaccines for Ebola were just total godsends. And I hope that's what I said, although I'm sure you're going to go back and check it. I would never have predicted that we'd have information around the time of the election. I never would have predicted we'd have it before the election, which of course we didn't, unless it were leaked. But this is utterly remarkable. This is what we've invested in for the last 70 years, and since Rosalind Franklin and Crick and Watson, since in the 1940s. This is 70 years worth of molecular biology come home to roost.
Yeah. And George, what was plan B if the vaccines hadn't worked? Was it going to be herd immunity, or was it going to be therapeutics eventually catching up to this?
It's hard to say. It's hard to, nobody really envisioned that this lockdown would go on this long. We thought it would be a couple of months. And then we would be able to get into summer and people would spread out and it would drop down. I mean, I don't think we anticipated this kind of rebellious behavior. I don't know quite what the right word is. But it's, sort of antisocial behavior. But it's, I never would have predicted that. I think the one thing that I guess the plan B would have been, I don't know. You got to have therapeutics. You can't, with a disease with this kind of mortality. I mean, by then we knew about the Swedish experience too, which was a failed experiment of trying to protect the frail and just letting everybody else exhaust the virus. I mean, that was clearly a failed experiment. And so I don't, that might have been somebody's plan B, but that went away real quickly. So I think we're always going to hold out for vaccine, Bob.
Yeah, yeah. All right, let's move to today. Kirsten, everybody sort of has their needle set somewhere between optimism and pessimism. Where's yours set today?
I'm a sort of a middle of the road type of person. I think probably because I see the world through a health equity lens, and I see the pandemic not just through the health equity lens, but feeling at every step our failure to focus on equity has been the reason we've not had as good a response as we ever think we're going to have, because the virus is always hanging around. We never quite get rid of it. It's hanging around in communities that we have not really invested in to make sure that we can lower transmission. My pessimism, when I'm pessimistic, it's because I do think we still have gaps in vaccinations. I think we have a slow vaccination roll up that at every stage is not as equitable as we'd like it to be. And that inequality, that the challenge with that is that is also the communities where the virus is. And so, so when you overlay new variants and you overlay under vaccination in a community, that's where it's not working quite as well as we'd hope it would. And so that's what I'm concerned about. And that's for me why equity and effectiveness always go together. And that's where I probably have the most concern right now.
Let me ask you a follow-up equity question. We have a spectacular division of geriatrics here, and they are frequently pointing out to me that we've focused a lot on equity around racial and ethnic groups and poverty. Yeah. And when you really look at who got hammered, it was older people, and then there's discrimination there as well. What do you think about that?
That is absolutely right. And I think that, when you think of across the country that the deaths from nursing homes, somewhere between 20 and 40% of the deaths, depending on which state you're in, when you look and you know that happened at the beginning of the pandemic, you can maybe say, well, we didn't know so much, there's nothing we could have done. But when you see that in the winter surge, the exact same thing happened, you realize that this really is a failure to pay attention to our most vulnerable, a failure to pay attention to the sites and to think about strategies. And then when you couple with that, the fact that, nursing homes were both the place where people were dying and people were also on lockdown and living in prisons the entire time. And for us not being able to figure out how to do testing strategies better, how to use some of our monoclonal antibodies in a way better to combat spread in nursing homes or the devastation in nursing homes. I think that is absolutely spot on and correct.
Yeah, I think when I interviewed Atul Gawande a few weeks ago, I think he made the point that and I hadn't really thought this through, one of the political complexities here is a little bit like Medicare or Social Security, that the people that are at highest risk of dying maybe trying to be careful, but the people who are at relatively low risk of dying may feel like I can be out and about and not be all that careful. And you have this sort of asymmetry of behavior and risk that always creates political conflict at some level. Does that resonate?
Yeah, I think that is right. And then I think we have the tendency to our rhetoric always thinks about one group or another group. I think if you thought about in reality, it's of course not that, right? So if you look at the CDC reporting how the outbreaks at college campuses leads 3 weeks later to outbreaks of older people dying, right? These are not separate communities. These are in fact all of our communities. We all know people at all ends of the age spectrum. And I think it's a little bit of the failure to think in a unified way about the policies related to the pandemic and thinking that, it's more about transmission. It's more about protecting the most vulnerable, that really misses the mark of what we're all trying to achieve.
Yeah. Peter, where are you in your optimism, pessimism?
I completely share KBD's even sort of keeled approach, but I would say my gas tank is about 3/4 full. And the 1/4 that's empty is really about equity. And it's not just about local equity and domestic equity, but global equity. And I'm really talking about vaccines here. And one of my really shocking, galvanizing moments last year was when President Trump, seceded from the WHO, and I said, "Damn, we're going to be, in a really deep rut for a long time." And then what that meant from an equity perspective globally for vaccines was that he wasn't going to pay any money into COVAX, which was a way that we were going to fund vaccines to middle and lower income countries. And it's still a big issue. In fact, vaccines are being used by India, China, and Russia for diplomacy without necessarily thinking about their own people. So I think you can weaponize vaccines, but you can also be humanitarian about it. So it's a really fine balance. And today, I think in the last day or so, there's an article in Science talking about the variants in these outbreaks, and it all overlays to what KBD was saying. Like, you can't solve this until we are all solving this, or we're all protected, because we know that from this Science article that the variants really occur in these outbreaks. The more outbreaks you have, I know we've seen it domestically too, but until we solve the rest of the world, what are we going to do? Like, have a new vaccine every year, some multivalent vaccine? And that seems really depressing to me.
Yeah. All right, George. So where are you? And I think, and both Kirsten and Peter emphasized the equity issues, both local and global. And one of our questioners and one of our audience said, what about Texas? So sort of how does the fact that people and states are letting their guard down, perhaps prematurely, influence your level of optimism, pessimism? So it feels like there's the sort of behavioral and the politics piece, there is the variance piece, and there is the equity, local, global piece that are all sources of some pessimism. So that's a lot to chew on. But how do you sort of pull all that together and tell us where your head is at these days?
Thanks for summarizing for me, Bob.
Yeah, okay. Are we done?
I have to say, I'm about a quarter happy. And what I'm unhappy about is every place else in the world. I think we have this sort of three quarters. I'm kind of with Kirsten on that. There are a lot of equity issues to fix. There are going to be pockets of under vaccination that we need to clean up, pockets of under immunity that we're going to need to clean up. But I think we're well on the way to do it, at least in California. Now, of course, there are a bunch of,
Careful.
No. I'm merely repeating what the president said or what the governor said. I think of the word he used.
The president said Neanderthals.
Yeah, Neanderthal thinking, please. He used it as an adjective, not a noun. The governor said reckless. I think it is reckless, and it's going to hold the rest of us back. And the worst thing is it creates the opportunity for even more complex variants to come out. But what I really worry about is the rest of the world. We're not going to get back to normal until all our as an economy, until all our trading partners are got things under control. And the only one that does is China, right? The most cross-border crossing in the world is the San Diego-Tijuana border crossing with 325,000 crossings a day. Whoa, what are we going to do about that? It's, I think we need to really be paying attention to the international aspects of this. I think COVAX is a mechanism. I also think that we have the chance now to kind of rethink PEPFAR a little bit more, the Presidential Emergency Plan for AIDS Relief. And whether that gets layered on, whether there's a new entity created that takes the Presidential Malaria Initiative and some of the maternal child health initiatives and kind of recombines it to a much larger global health assistance program within the Department of State. I think that's something that we might be looking at here within a year, because we're not going to solve our economy until everybody else has things under control, reasonably under control.
So
even with immunity passports.
Well, we'll get there. Yeah. So let me just stick with George for a second and maybe connect the dots for us. I could see somebody saying, all right, it's sad that people in Mexico are behind us, or it's sad that the governor of Texas is acting irresponsibly. But as long as everybody or 80% of people in California are vaccinated, all right, we're fine. And tell us why that's not right.
Should I quote John Donne for you, Bob?
Sure.
No man is an island unto himself. What happens here happens there. I'm paraphrasing now, and it ends up, ask not for whom the bell tolls, it tolls for thee, right? So, we had this figured out in the 17th century. Why can't we remember that,
Yeah. But tell us why, from an epidemiologic and a virologic standpoint, why is it that even if we have gotten to a point that, let's say we reach herd immunity, whatever that truly means, in California, why what they're doing in Texas or what is happening in Mexico is important beyond the obvious humanitarian? It's important because
no. It's because we're going to get constant reintroductions of even more and more and more complex mutations, things that have drifted very far from what the vaccines have induced immunity to, and what naturally acquired immunity covers. So that's the problem.
Yeah.
I mean, we don't have to invoke, mink farms in Denmark and, the tigers in the Bronx Zoo and all these other kind of, species jumping things that could go out and have a bunch of mutations and come back in. Just take up the whole rest of the world, or states outside of the United States, outside of California.
Yeah.
So it's a matter of self-preservation to try and get this under control. Around the country and around the world, and we can't kiss it off. Right?
Yeah, I wanted to emphasize that point because I think people sometimes say, all right, if we have reached herd immunity, we're good. It doesn't really matter. But the point is we're going to get nastier viruses coming at us. And some of them are going to be vaccine resistant.
Herd immunity is about populations that mix. I heard UC Davis say they think they had herd immunity in their medical centers. Nobody ever goes home. What? It's about populations that mix. And, if we want to put up a wall around California, and if I were doing that, I'd suggest we grab Baja California while you have the chance, because it's great surfing beaches. But, if we want to do something like that, well, fine, right? But we're not going to do it. And It's not the way it works. And, we need to have, we need to act as part of a united group of states and a larger group of countries that are our trading partners.
It's such an important point that is just missed in the 80% herd immunity mark, is that it fails to capture how there can be so much heterogeneity and under immunity within that 80% in a state, or that the states are we're moving across states. In a state like California, with its international travel and its cross country travel, there's no way that we're going to be fine just saying we're at 80% without attention to all of these other issues.
Right.
George, I thought it was interesting.
It's a great short-term goal, though, right? It's a great short-term goal.
Yeah.
But it's just
Totally agree.
Get you out of the soup. Yeah, go ahead, Peter.
Oh, George, I was wanting to know your opinion on. I thought it was interesting that when California the state announced on Friday last week that we're going to open up amusement parks again, that the clause of only being a resident of California to be allowed into that setting was an interesting one, which again gets to this flawed idea of what herd immunity is, which is if we can clean up our state, it'll make it a safer amusement park. But then, it doesn't get to that cross-pollination aspect.
Yeah. Peter.
Yeah, well, yeah. I mean, and I can tell you didn't grow up in Southern California, Peter, because the thought of being at Disneyland with 20% occupancy, I was gassing up the car when I heard that. So.
Peter, I have to say the news on the variants a month ago was dire. And then, 2 weeks ago in Brazil, and now you're sort of hearing all this bad news. Feels like the last week or so, it's been better news. Is that the way, in terms of the vaccines still seem to work pretty well? The South African and Brazilian variant don't seem to be growing in prevalence in the US very much. The UK variant seems to be susceptible, all that kind of stuff. Is that your take as well?
I think my take is optimistic for what we know about. And speaking of what George was saying, it's what we don't know about or what's coming. It's really getting me nervous because, again, unless we quell the world of these outbreaks, this virus is going to mutate at least every 2 weeks to something that's going to be potentially worse and have more superpowers than just, mutant that's evading the current vaccines. But yeah, for the ones we know about, but I like with variants, I always feel like I'm walking around with Vaseline on my eyes. I only know about what we're testing for, which is less than 1% of the variants in the US. But it's the future and what I don't know about that's scary to me.
Okay, so we're going to get to the future in a second. One last question about today and looking back a little bit, which is, it feels like the schools are the most controversial issue of all. As you reflect on the past year and think about where we are today, what did we get right and what did we get wrong on the schools? I don't know who wants to take that. I know, George, you've had some opinions about this. You want to start?
Sure. We basically got the schools wrong. Now, with the information available at the time, we did the right thing. And then once you go down that path, it's impossible to get out of it. Although, we're now getting out of it, and some other places have been out of it for a while. All the Marin schools went back, I think, in last fall.
Yeah.
And it's, it gets, it's always in public health, it's always easy to close something.
Yeah.
You can issue the boil water order, you can shut down the sewer, but getting it reopened is always the hardest part, right? And this was just yet another example of that. What the playbook says for influenza A is that in the setting of pandemic influenza A, the biggest amplifying entity are elementary schools. And that's what you shut first, right? So that's why that happened. Now, it turns out that this doesn't have the same kinetics as influenza A. And now we know that. So now when we get the next bat-associated beta coronavirus pandemic, we'll know that we can skip that step. But at the time we didn't know it. So we basically had to do it. And it wasn't public health who ordered the schools closed, by the way. The schools closed themselves. But then it becomes really hard to reopen. And I think the larger lesson here is that it's easy to close stuff. It's hard to reopen it.
Yeah,
I would
I think
Go ahead,
yeah,
Bruce.
and I think as much as we've talked and patted ourselves on the back for San Francisco's success, I think then the inability to open schools when our case counts were low will be that will be the thing that we will have to reckon with when we look back at this. And I think the degree of distress caused about the discussions about schools, but caused for everyone living through the pandemic, I think it was only heightened by that, and I think it'll be something we will have to think about for a long time.
Yeah, I want to extend what Jorge and KBD said, and saying that the schools in part one of the California pandemic, when we were all listening and doing everything right, was appropriate, but in part two, when the natives got restless because the science wasn't aligned with what we were being told, I think for me personally, closing the schools was a travesty, keeping them closed, even though by the fall, and I remember in October, nothing was going on. We were like, breathing from the summer, and there was no reason to keep schools closed. Mm-hmm. We had a chance then, and we blew it, led to a lot of distress in the community. People were losing jobs, they had to stay home, they couldn't tutor their kids, they didn't have bandwidth. The schools were giving all these other resources. Other schools were open, not public schools, was creating more and more division. So it created a lot of restlessness, and that pandemic fatigue turned into pandemic resentment. I think schools was part of that.
Yeah,
absolutely.
Are you with George that the initial decision was not irrational? It was sort of based on Pandemic 101?
Totally. I mean, we didn't know enough then.
Yeah, interesting.
And the Chinese closed all their schools, by the way.
Yeah.
So that was the example we had to go on.
All right, we have about 10 minutes left. I want to focus on a year from now. So where will we be a year from now? Maybe I'll start with you, Peter.
Well, coming back to my Tamiflu example, I was very pleased that Merck, although they had failed vaccines and although they're partnering now with J&J to bolster production, they do have 2 successful oral agents on the pipeline. And I think that will be interesting to see how it plays out. I think that, in terms of, coming back to that vaccinating the world issue, we won't be there 1 year from now, and that will be sad. I think we'll continue to see variants, and there'll be a lot of discussion about surveillance and what should we put in the next generation of vaccines, and how many valents can you crowd in for, like a flu vaccine or not? How often do people need to get it? But there'll be a bigger divide between these countries that are doing these new vaccines and then the rest of the world that hasn't. So that's the second. And then third, even if we do all these things, we're not going to, and this will come back to Jorge's expertise, but we're not going to eliminate COVID, unfortunately. We've only done with smallpox and that horse pathogen you always talk about.
Cow
Pathogen, sorry. But it's going to be around with us, and whether or not it's going to settle into an annoyance of an illness, but then there's a prospect of long COVID that is scary to me as well. Like 10 to 33% of people with all these range of symptoms, more in women. We still don't know about it. How do you treat it? Even if you get this asymptomatic disease, you might get it. So these are all questions that are still needing to be answered.
So if I've gotten my 2 shots already, Peter, what's the chance I never need another one? Is it 0?
It's 0.
0. Okay. Kirsten, what do you think life is going to be like a year from now?
Yeah, I'm going to look at this through our equity lens. I think there's a lot of focus now, rightly placed on we need to get vaccinations in and in these communities that are hard hit. But these are communities that have been really suffering through an economic crisis and also have other health needs that we've not quite paid attention to because we've really been remote and trying to think of other things. And so I think on my optimistic days, I think a lot of the innovations that have really happened during this time in what the state has put together regarding how we address those experiencing homelessness, other types of community investments that have taken place in response to awareness that has been raised because of the pandemic. Those things make me optimistic. I think, though, the need is great. And what I hope is that we don't just forget this all as we move to our, the immediate threat of the pandemic is no longer right in front of us, but really address the ongoing needs that we're going to need to really address health in these communities. I am optimistic, though. I have to say the types of partnerships, both with the community and with public health, that have really developed and been strengthened during this time, I think is really quite encouraging if we can keep this going.
Yeah. George, how about you?
I'll defer to Kirsten on this question, but I'm thinking the Warriors are going to be 39-2 this time next year coming out of the All-Star break. What I would hope we would be able to do, I think things will be pretty much back to normal. What I hope we would be able to do is to set up these early warning systems that USAID managed to disassemble in October of 2019, including one based at the Wuhan Institute of Virology, specifically that looked at beta coronaviruses in a particularly prescient move. Great job saving money, guys. I think that's what I would really like to see out the other end of this. Now, that may be more like a 5-year program. That may be more like 5 years out. And I fully expect we're not going to be anywhere near getting the world vaccinated by this time next year. That's going to take a couple of more years, and we're going to have to deal with either with developing a universal vaccine for all the beta coronaviruses, or chasing variants all the time. So I think that internationally there's a lot more, there's going to be a ton more work to do, not only in terms of getting everybody vaccinated, but also setting up the surveillance system so we can spot the next one of these coming down the line, which, by the way, the Chinese did a pretty good job of. And it was, there were a lot of mistakes that were made, and we can't afford to make those next time. And most of them were on our side, by the way. So
yeah. In terms of kind of practically next winter or 2 winters from now, do you see, does Tony Fauci come out and say, we've detected new viruses here and everybody masks back on and we're closing this and that? Or what is it going to feel like?
It'll be 25 years from now, Bob. Yeah, I mean, it'll be, I think what we're going to, I think what we'll do is we'll get through this summer. We'll have to see what happens in the winter. There could easily be a winter surge if we don't get enough people vaccinated, easily. And even in California, if we have only 20% of people unvaccinated, that's 6 million people. They can sustain a lot of infection, right? 6 million adults. And I think we're going to have to get through the next winter, and then we can start see whether it starts to kind of gradually attenuate over time. Like the other main beta coronavirus that really we think of as a sort of a nothing, summer cold deal, the OC435, which, oh, by the way, may have been the cause of the 1890 influenza pandemic. And it's now just like a ho-hum thing.
Do you think everything is open this winter and at full capacity? Bars, sports stadiums?
Domestically, yeah. I'm thinking I was going to try and answer the question more internationally.
Yeah.
I think that there'll probably continue to be travel restrictions.
Yeah. Okay. Maybe last question for all of you. You've been dispassionate observers and scientists and all of it. Tell us about the last year personally. How has it affected you? Has it changed your life, both for the worse and maybe for the better as well? Peter, you want to start?
Well, I reflected back on 1 year ago or around that time, and I remember the fears that we all had were, I remember that first patient I had and asking the nurse to help me figure out if I put on the PPE correctly, even though I'd done it like a zillion times before for TB and C. diff and all that stuff. But I was so scared. But my terror wasn't even matched to the terror that I had of bringing that home. I remember taking my shoes off my trunk, taking a shower, doing all of that, because we didn't know at that time how easy it was to get from surfaces or not. And I would be much more scared of bringing that to somebody who had no part in this business. I was taking the risk, but not them.
Mm-hmm. Yeah. And how your year has been, you've spent a lot of time explaining things to people, doing a ton of media. That'll probably go away over the next 6 months. Will you be sad about that? Will you be happy about that? How's that going to feel?
Well, Brian Schwartz, my academics boss, already started preparing me for that. He said, what are you going to do after they stop calling you to be on TV? And you better get ready for it because you're going to get really depressed. So, but I won't get depressed because this is part of my job, this kind of, articulating or bringing complex concepts into simple things. It's part of what I do with the students, with the residents, with the fellows all the time. So I think that joy will still stay. Regardless of if I'm talking into a box or not. So I think I think this is the corny part. I do know that I will not take things for granted anymore. My UCSF colleagues, we haven't seen each other in ID, for example, forever as a group. And, there was so many joys of, sure, we complain about the free lunch or whatever, but it was free and food was a big motivator for me. And that was gone for a whole year, but at least I'll get that back.
Yeah, I understand you haven't had lunch for a year.
Yeah.
Kirsten, how's the year been for you?
Well, I think in many ways professionally it's been extraordinary. I think it's pushed me professionally into places I didn't think I would ever go. I have new collaborators that I didn't think I would ever have. And that has been really, really terrific. At the same time, it is, I don't know that I realized I could work in this many different domains at the same time. Personally, my life and all of our lives are so disrupted. And I think if someone had told me that a year before, that you would be doing all of these things and you would be doing them at a time where you couldn't go out and you would worry for your 84-year-old mother who lives with you and other people around you, I don't know that I would have thought that would be possible. But I think it's amazing what we can stretch to do. And I feel really fortunate that the health concerns that I had for my immediate family have really, they've all remained healthy, and that's been good. And I'm looking forward to things getting back to not being in the high adrenaline state all the time. But I think overall, I think it's been remarkable, and there've been many opportunities, frankly, during the pandemic.
Yeah. All right, George, give you the last word. How's your year been?
Extraordinary. Extraordinary. I think Kirsten's right. I think at the end of this, I'm going to need an adrenal gland transplant because mine are exhausted from working every day since last February, basically, and but lots of work every day too. And it's you basically. Chip Schooley from UCSD told me that there'd been 64,000 articles published by October. Trying to stay on top of that literature is pretty daunting, and we had great help trying to stay on top of that literature. I think that's our jobs have been to digest and basically feedback. There's a great word in in Portuguese, retroalimentação, meaning feedback. It would mean sort of yakking it up, actually. Kind of giving you, trying to redigest and get this into understandable parcels of information, not only for the greater public, but also for politicians and policymakers, and trying to find the little gems in the literature around things like right now, and one of the things we're dealing with is can ring vaccination work around variants?
Mhm.
Is that something we should be doing? I think we should be, but I got to find this tiny little nugget that says that it works. So we'll have to see, and I'm going to at least keep at this for a while. So
Yeah.
And the wonderful thing about UCSF, Kirsten and I see each other every day, but Peter, I know from the education part, and other people that I've dealt with a lot, like Sanziana Roman from surgery. I never would have come across her before. Bob Harrison, I deal with a little bit, but it's sort of different talking about the chicken evisceration line at Foster Farms. There's no kind of greater bonding experience than that. So it's
It took me a while to get that, Jorge.
anyway.
Well,
That's the wonderful thing about UCSF. Everybody's ready to help.
Yeah.
True.
I think that part has been enormously gratifying. And as David Axelrod liked to say about political campaigns, they are MRIs of the soul. And I think a pandemic is an MRI of an institution. And I think, UCSF has come through with flying colors, and the quality of our colleagues, not just what they know, but how they care, has been really, really impressive. And you three are very high on that list. I've learned a ton from each of you, and I know everybody out there has as well. So hopefully this thing will go away. Hopefully, Peter, you'll find something else to do that's gratifying. George, hopefully you have an audience to quote your Portuguese and your literature too. It's, but as you all say, we're not completely out of this yet. We've got a little while to go in the world. It's an awfully big world out there. So with that, let us quit. Thank you for taking the time to be with us and educate us now and for the last year. Thank you to our production team. You see them up here, and they put this on flawlessly every week. This will be posted on YouTube tonight, probably about 7 or 7:30. And we'll be back next week for a non-COVID themed grand round. And then the week after that, we'll have another COVID themed grand rounds, and can keep doing that as long as there's a pandemic. So stay safe and stay well, and we will talk to you next week.